Good afternoon. The Jefferson College of Nursing Visiting Scholar Series, Project Firstline, Infection Control Training Implications for Nursing Education and Clinical Practice, October 21st, 2022. Thomas Jefferson University Hospital Incorporated is approved with distinction as a provider of nursing continuing professional development by the Pennsylvania State Nurses Association Approver Unit, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. RN participants who successfully complete this activity will be awarded a maximum of 1 contact hour. Participants must attend the entire program and complete online evaluation in order to receive full content hour credit. None of the planning committee members for this educational activity have relevant financial relationships to disclose with ineligible companies whose primary business is providing, marketing, selling, reselling, or distributing healthcare products used by or on patients. Michael Bell, MD, faculty for this educational event, has no relevant financial relationships with ineligible companies to disclose. There is no commercial support and no joint providership.
And welcome to the Jefferson College of Nursing's Visiting Scholar Series. I am delighted to welcome Dr. Michael Bell, along with fellow Jefferson alumni, faculty, students, and employees for an exclusive online talk where he'll describe Project Firstline, the Centers for Disease Control and Prevention's National Training Collaborative for Healthcare Infection Control. This incredible education program, created in collaboration with many partner organizations, including the American Nurses Association, provides frontline healthcare workers, students of the health professions, and members of the public health workforce the infection control education they need to protect patients, communities, and the nation from infectious disease threats. Dr. Bell's talk is particularly timely, for this is International Infection Prevention Week, a time when we recognize the importance of infection prevention and control in making healthcare safer for all. I will now turn it over to Dr. Mary Lou Manning, my Senior Associate for Strategic Initiatives and a professor in the Jefferson College of Nursing and an expert in infection prevention and control in her own right.
Hi, this is Mary Lou. I'm thrilled to introduce my colleague and friend, Dr. Michael Bell, to present Project Firstline, Infection Control Training Implications for Nursing Education and Clinical Practice. Mike is Deputy Director of the Division of Healthcare Quality Promotion in CDC's National Center for Emerging Zoonotic and Infectious Diseases and lead physician on Project Firstline. An expert in drug-resistant pathogens and hospital-acquired infections, Mike's career has focused on investigating and preventing transmission of healthcare-associated illnesses, development of evidence-based infection control guidelines, and optimizing systems of care. He has been instrumental in advancing programs for prevention of antimicrobial resistance and improvements in safe medical practices. Mike received his medical degree from the University of Washington and trained in infectious diseases at the University of California, San Francisco. On a more personal note, I know Mike to be a passionate advocate for advancing healthcare safety and quality and a master educator. I always find his advice, his lessons incredibly practical. One of my fondest memories in working with Mike was in 2015 when we presented together at an opening plenary at a national conference on the topic of preparing globally, acting locally, applying infection prevention lessons learned from the Ebola crisis. I would venture to say that many, if not most, of those lessons can apply today. So Mike, on that note, I turn the program over to you. I'm delighted to have you.
Thank you so much. Thank you to you and Dr. Marino for having me today, and welcome everybody. Thank you for taking your time to join us. I can't tell you how excited I am to be sharing some thoughts with you. I'll first start by saying that, let me share my screen very quickly. The genesis of Project Firstline is something that's not, whoops. Is that the one that I want? Yes. The genesis of Project Firstline is something that has been simmering for a while, probably since that 2015 conference or so that Dr. Manning just mentioned. It's not news to any of us that infection prevention and control is a hard thing to implement perfectly. It's certainly not something that can be done by just the infection preventionist or nurse leaders in a facility. It's something that takes everyone. So the underlying driver of Project Firstline is to grow the team to be as big as it possibly can be. We need everyone's help in this. When I think about infection prevention and control, I think a lot about who actually does it. And, those of us who tend to write the guidelines or look at the data, do the analyses, we're not actually the ones doing infection control. Infection control happens every single time someone has contact with a patient or with the healthcare environment, right? It's every respiratory therapist, every nurse, every physician, every environmental services technician, every triage person and intake person, all of them are having direct interactions with the environment or patients that can either contribute to safety or undermine. And so getting everybody on the same page and bringing information to them in a way that makes sense is what this is all about. Project Firstline refers generally to the fact that that is our first line of defense. I'll be honest, it was originally going to be Project Frontline for frontline staff, but Frontline is a flea and tick treatment. Those of you with animals will know this. And so we didn't want to create that confusion. So Project Firstline it is. A quick word to frame infection control versus infection prevention. Infection prevention became very popular in the past decade and sort of replaced infection control. But I want to point out that there are two different things, at least in my mind. Infection control is what you do when you're trying to keep something from spreading, right? So when there's an outbreak of something new, it really is infection control that we're after. In contrast, infection prevention, to me, is the array of processes that we know how to use that can prevent the infection from happening in the first place. So the central line insertion bundles, the ventilator-associated pneumonia prevention bundles, those are all infection prevention, right? We know that infection can happen if we don't do things right, so we have a system to make sure everything is done and done correctly. Infection control, though, is a little bit broader and more responsive to what's happening in the moment. And it doesn't have to be tied to a device or certainly not an ICU. And so we need more people to be thinking about it. I will say that we pay a lot of attention to emergent threats, and I'll say a few more words about that in a moment. They're important. We need to do something about them, but the routine threats that are present in healthcare facilities, the ones that can harm patients or our staff, are always there. And we need to remember that all of the things that we do for infection control are there to protect us day in and day out, as well as when we have a recognized emergency. The goal here, in addition to reaching and recruiting more help across the fields, is to guide our healthcare landscape as it evolves. I think that anyone in the field right now shares my sense of profound alarm, grief to an extent, and determination to try and help when I look around at the incredible exhaustion that I see across healthcare systems, when I look at the erosion of staffing rosters, the amount of fragility and brittleness that I see in our health system, it's extremely concerning. The fact that our health system is strained because of personnel, professionals in nursing and beyond, that to me is something that is existential. And I think we have an opportunity that we must take to make things better. And I don't mean better just in terms of outcomes, right? It's fine to have metrics and track outcomes. We need to do that. But I also think about the environment of care and the environment of work. I am passionate about improving the day-to-day lives of all of our colleagues. And I say that because our work should be some of the most joyful stuff out there. I can't imagine a more rewarding career than to be taking care of patients. And yet when you're short-staffed, when you are running, literally running to hang an antibiotic in time or to, get a task finished so you can jump to the next task, the level of stress, the lack of joy in that, I think really takes a toll. And so some of this is about changing how we think about many of the infection control and infection prevention things that we do, and drive it more based on a deep understanding. At the bottom there, I have the concept of intuitive versus prescribed. Prescribed things that you are required to do because there's a list and a chart on the wall, that can be helpful, especially during an emergency. We've all seen plenty of donning and doffing posters, and those are nice reminders. But that's not the way to go from day to day, hour by hour, relying on that kind of prescription, right? You really want to internalize the understanding of what you're doing and why, so that it becomes intuitive. I want the ability of every last person in healthcare to intuit what the right thing to do is, to be more common, to be routine. One of my favorite moments, even though it's a horrible story, but it has a silver lining, sort of. And that was a physician who reused a syringe. In fact, he loaded a syringe with flu vaccine and went down the row of patients in the waiting area and just gave flu shots without changing the needle or the syringe, which is ghastly. This was about 9 years ago, so it's not that far in the past. And it was in a major metropolitan area that shall go unnamed. But the good news is the receptionist who was watching this said, I read that you're not supposed to do that. This was roughly around the time that the endoscopy clinic in Nevada was shut down because of syringe reuse. And the receptionist said, I read that that's wrong. We need to call the health department. And they did. They did all the right things thereafter. Unfortunately, nobody got infected. But it is the example that I like to think about in terms of the value of having everybody on board. I can't say enough for how much that means. So, for the emergent pathogens, what are we looking at? Well, if you go back to the early 20s with SARS, followed by MERS, then there was the 2014 through 16 Ebola and Marburg outbreaks, and then COVID-19, and then monkeypox. And now there's Ebola in Uganda that we're tracking hour by hour. Some of you already know this, that we've routed all of the travelers from Uganda to 5 major airports in the United States. We've done outreach to the regional facilities there to prepare them just in case they need to receive a possible patient. And to the greatest extent possible, we've done outreach to remind everyone the importance of being tuned in to the possibility that you could receive somebody who got missed in the border screening, got on an airplane, maybe didn't go directly out of Uganda to the United States, maybe went via Kenya or something, right? There's always that possibility that someone could end up on your doorstep. And we've always got to be diligent about asking those questions. Have you been traveling? In addition to having a fever, have you encountered anybody else sick? Those basics apply now more than ever. I won't even mention the fact that polio seems to be circulating again in some communities, and who knows what's going to be next, but I can guarantee you that there will be more. And so as opposed to saying we're finally out of COVID, we can relax, I think the reality here is we need to learn from COVID, understand what made us a little bit on the brittle side, try to strengthen those areas, and move forward as a health system that can accommodate the almost guaranteed endless series of challenges. As we see our population aging, as we see the population shift, there's always going to be more things. And add to that the effects of climate change, and we're very likely to see more emerging infectious diseases. On the home front, as it were, our routine healthcare-associated infections did not fare well during COVID-19. We were on a really good downward trend for almost all of our routine healthcare-associated infections until 2020, 2021. And since then, we've seen significant increases in central line-associated bloodstream infections, CAUTIs, ventilator-associated events, and MRSA bacteremia. This, I think, is clearly tied to the fact that our intensive care units have been swamped, that COVID resulted in so many people on ventilators, so many people critically ill. If you think about the practical challenge of suddenly having to take care of patients in a prone position as opposed to on their backs, that too will clearly add burden and difficulty to routine practices. So it's not surprising, but it's a very important warning sign that says that all of the advances that we've made, all of our successes are not hardwired. They're not built in stone. They're pretty fragile, and we need to be able to accommodate challenges without losing ground like this. I think we have a moment of opportunity to regain the ground we've lost. There's no magic there. A lot of it is getting back to doing the things that we know to do. Some of it is about stabilizing our workforce. It is really hard to maintain quality if there's tremendous turnover, if we're relying on a lot of temporary nurse staffing and so on. And when you reduce staffing for people like respiratory therapists or environmental services techs, that just compounds the problem. Interestingly, we didn't see a bump in perioperative outcomes that were bad. And C-diff actually didn't go up either. So, there's some good news. There's some things that weren't directly affected by COVID, but several things were, and we need to be on the lookout for that. And then, it's October, and what does that mean? Respiratory infection season is well upon us, right? So amidst all of this, if I show you on the left-hand side, you can follow the pointer. That peak there is the historical peak for RSV, and that is October, which is us. You are here. And then over here for influenza-like illnesses on the right, all of those different colors are just different years. But what you can see there is that October is right at the beginning of the chart. And so the coming month to 2 months is when we're likely to see a big bump. Oops. So that is all to say that we have our work cut out for us. I do think that if nothing else, COVID will have made us pretty robust in our ability to manage severely ill respiratory patients. But that alone is probably not going to be enough. So thinking ahead about how we maintain a healthy workforce and what that looks like in terms of carrying forward some of the value that we've gotten from COVID, I will sort of digress briefly and say that one of those things is source control. Using a mask to prevent exposing others and asking everyone in a healthcare facility to keep a mask on while they're there is something that we've seen be extremely effective across multiple different healthcare settings, from long-term care to acute care to ambulatory settings, all encompassed. And that's something that I hope we don't lose. I'm actually very encouraged because even though CDC is now saying that you don't need universal source control when things are not at a high level for COVID in your community, there are many facilities that are deciding, yes, but it's not just about COVID. We can use this for other respiratory infections, including RSV and influenza. And so we're going to actually maintain universal source control for the coming season. I think that is a very exciting development in the sense that it means people are now thinking about source control as a very active tool that you can use. And that's exactly how it should be. It shouldn't be something that is put upon you by public health. You have to do it because you got told to. It's kind of like, I don't know, earmuffs on a cold day. There's no rule that says you have to wear them, but they're nice and they'll keep your ears warm. So let's pull out the earmuffs. I think that masks should sort of be in the same category. And it's nice to see them not being as politicized as they have been in the past. So what is Project Firstline doing about this? Part of it is to really focus a lot on the why behind the what. I mentioned all the many different lists of rules that we've seen posted on walls and so on. And I'll say more about things posted on walls in a minute, but the rules alone don't stick with you very long unless you know why they're there, right? It's easy to get confused about the order of donning or doffing if you're not thinking about what it is that order accomplishes. And so as we go through the slides, I think what you'll see is a theme of helping people understand the why behind what we do. So if you look at this chart, this diagram of infection transmission, along the left, what you see are the different steps that an organism, a pathogen has to take in order to actually cause tissue damage and infection. that is something that, I think I made this slide originally when anthrax was released back in 2001. I had to go in and talk to the coroner's office where they were refusing to go in the building because that first gentleman who passed from anthrax, the journalist, was in there, and everyone was terrified. And by going through the steps of what would have to happen for anthrax to go from a human being who died of it to becoming an infectious spore again, it made it much clearer for people to understand why I wasn't concerned about going in, and why they could go in with confidence and maintain good, appropriate environmental hygiene and otherwise be fine. And that's what we ended up doing. But if you look at the steps, first and foremost, a pathogen has to leave wherever it is. It doesn't have arms, wings, legs, or anything like that. So it has to somehow get out. It can be coughed out. It can be released through drainage or soiled dressings. Once it's out, it needs to survive. A lot of pathogens are pretty fragile. And so there's that survival step. And then it needs to get to where it's going, and that place that it goes to has to be susceptible. And in healthcare, that susceptible part tends to be the mucous membranes of your eyes, nose, and mouth, right? They're the most delicate, susceptible part of our skin. Intact skin on your forearm is actually pretty durable and not prone to getting infected, with a few exceptions. Things like, I don't want to give you the creepy crawlies, but we've all had that feeling when we walk into a room with a patient who has scabies. Scabies is one of those things, molluscum, maybe herpes viruses. But aside from that, most other pathogens really need to go through a skin break or through mucous membranes. And so that susceptible part is a really important component here. And then lastly, we have our own host defenses, either our own immune systems or vaccines that can bolster that immunity. And those things all contribute to keep us from getting infected. So if you look to the right here, the leaving the original site piece, the reason that's important is it gives you an understanding of why we do containment and source control. The survival in transit is interrupted by good cleaning, disinfection, and hand hygiene. The delivery can be interrupted by good air handling, sharps management, and so on. PPE is all about protecting the susceptible parts of us. This is why when I see leg coverings in a lot of situations, I'm kind of noting that, there's either a belief that something's going to get to you through your knees, or you're expecting a level of messiness that's probably inappropriate in a healthcare facility. And then lastly, I mentioned immunization and so on to bolster our own defenses. So that is a snapshot of the infection transmission why. The Project Firstline why is about the fact that we have not done a great job as a profession of reaching everyone, right? We have a tendency to have trained people using talks like this one that last for 40 minutes, that require people to sit and watch a presentation. We have tended to focus on people who are inherently interested in or managing the topic of infection prevention and control. And that's not the huge number of people who are out there actually engaging with patients in the environment, right? We're missing most of them. And frankly, most of them don't get an hour-long lunch or a grand rounds opportunity or travel to a meeting to get this kind of education. We need to be able to provide information that is concise, that is deliverable in a format that makes sense for a larger array of people. And by that, I generally mean smartphones these days. And it has to make sense to them in terms of what they do and how they communicate. And so it's a big ask, but that has been the driver of the clear language approach, the adult learning science that we've applied to get people to not only understand the why, but also recognize risk. The Project Firstline portfolio has a lot of content about risk identification. That was something that we decided on as a first tier of content that we wanted to deliver. As I mentioned, this is something that was envisioned well before COVID. We actually launched just as COVID hit. And so we tailored our content to be more responsive to COVID-related needs in the first 2 years. But a lot of the content is much broader than that, as you can see here. It's about recognizing risk. It's about understanding where there are germs, either in the environment or in the human body. This is wrapped up in a variety of toolkits that you're able to download. I'll give you all of the web links at the end as well, so you don't have to write anything down. But getting people to understand that there isn't a need for mystery here, right? You shouldn't walk into a room and have no idea where infection risk could lie. You should be able to, look around and see that, wow, that bedside table that was just used for, I don't know, phlebotomy, might have blood on it. And so there could be hepatitis virus there. The bed rails of this person who has C. diff very likely has a few spores on it, right? And so if you're going to touch the bed rail, then that means you need to do hand hygiene right away. Getting people to sort of think through that process so that it's not about being surprised that you got something. It's about walking in and thinking, those are the hot spots that I need to pay attention to as an individual who doesn't want to either become infected or become a vector for infection. We have interactive products that are intended to be used very quickly. For example, as a team huddle at the beginning of a shift. These are sets of thought exercises in a way. You can see the thing in the middle asking, what's the first thing you should do? Basically, rather than having people look at the list going, okay, here are the rules, remember them. It's more about having a dialogue and saying, why would you want to do that first? And what's the upside of doing that first instead of doing something else first? One thing that I think we also want to do, and I mentioned things on walls, I'll foreshadow that I'm going to close with human factors engineering, but as part of the work that we're doing in funding in that arena, what we're learning is that there is actually some science around decision-making and trade-offs. People are constantly making trade-offs. It drove me somewhat nuts when I first went to the human factors engineers. Oh, this is about 12 years ago, maybe. And I heard someone giving a presentation about human factors and nursing. And I was very excited to see this. And I sat through the presentation, which basically boiled down to nurses shouldn't be distracted. You shouldn't let nurses be distracted. That makes it harder for them to work. And that was the take home. That's kind of like telling the parent of 2 and 3-year-olds that they shouldn't be distracted at home. That's not how it works. Healthcare is about navigating through a universe of urgent distractions. And each and every one of us constantly is making a decision, okay, I was planning to take my gloves off, do hand hygiene, and do some charting. But now there's an alarm going off in that incubator over there. And if I don't go over there, the child could die. So I'm going to make a decision that I'll take my gloves off, I will skip the hand hygiene, put fresh gloves on, and go save the child's life, right? Very rational compromise, good decision, but it was a decision not to do the standard thing. The intuition that I mentioned at the beginning is what drives successful trade-offs. Somebody who is a seasoned healthcare provider will have already intuited that most of the removal of contamination will happen when I take my gloves off. I do hand hygiene afterwards because I might get some on myself as I'm taking them off, but I can quickly grab another pair of gloves, put them on, do this, and then do hand hygiene, and probably the negative impact will be minimal. We don't think about that consciously, but it's built in, and that decision-making happens very quickly. There's some early science coming out of Emory next door that we've funded showing that the more experienced you are as a nurse, the better you are at making trade-offs that cause no harm. People who are brand new make trade-offs as well, but they are more likely to end up creating an unintended consequence of the trade-off. And so that is exciting because it means that's a learnable thing, right? It means that our experienced colleagues are able to learn something that makes them better at this. And trying to distill that down and figure out how to spread that is part of what we're investing in. Continuing on with products, here are some more job aids and related materials. And here's one that I think is pretty interesting because it has a ripple effect. This is conceivably one of the least exciting things in our field, which is the EPA registered disinfectant label, right? None of us enjoys reading it, but for some people, it's pretty important to understand what's on it, specifically our environmental services technicians. The EVS staff, though, often will not necessarily have grown up speaking English, in which case, not only is it a dense and dry label, it may not be as transparent as we would like it to be, and that could be critical to their ability to be effective and safe. This is a document that we produced this past season in partnership with EPA to clarify the parts and content of the label. The value here is partly that it's plain languagey English, but also because it lends itself to translation. You can imagine that if you're not a native English speaker and you are able to see something like this that clarifies an EPA registered disinfectant label in your native tongue, that would be really helpful. And it's not that hard to do. And so this is the kind of thing that we're trying to knock out systematically. They're not necessarily rocket science, but they're value adds that I think are comparatively low-hanging fruit and reach a lot of people in a way that matters. Lastly, we are not the only ones generating stuff. As Dr. Manning mentioned, we have a variety of partners that we work with. I'll list them in a moment. But they're producing stuff in partnership with us as well. And I've always been a big advocate of borrowing knowledge from your friends. And so this is a great way to share expertise, insight, and innovation across many fields. Here you can see that we have a podcast that is ongoing with AMA. We've worked very closely with AHE, the Association for the Healthcare Environment. They're the ones who are the professional society for environmental services managers. And then there down at the bottom, the Pennsylvania Health Department collaborated with us for the Tyrannosaurus Rex poster, which I quite love. So with all of this, we have managed to reach millions of people. It's kind of exciting. It's high time, frankly, that we use social media and other current communication modalities to the greatest extent possible. I think that in this day and age, we have an opportunity to do a great deal of work and have a great amount of impact through these pathways. And that's just the first year. This has been done with public health partners. We have reached out to specific health partners, looking at city and county health departments and state health departments, but we also fund all 50 states plus major city health departments through the CDC's EpiLab Capacity Cooperative Agreement. And that is how we support the HAI programs, the Healthcare Associated Infection Prevention programs. We're also the biggest funder of the state laboratory component of the public health system in terms of AR diagnostics and detection. And so we've leveraged that and in parallel funded the same partners to carry some of the messaging forward and to be distributors of some of this content. We have an array of academic partners. This is the current list and it's likely to grow. We want to get the partnership list to be bigger and bigger as time passes. Clinical entities are here, including some that are very subspecialty specific, some that are regionally specific, and so on. What we're learning is that in a country as large as the United States, every region has specific challenges. Every region has different populations that they're either trying to support or that are supplying the workforce, and making sure that we tailor appropriately and create enough flexibility and variety so that everyone has something to gain is part of our mission. I'm going to say a last couple of words about human factors engineering. It is an area that I am currently trying to promote, not to healthcare, but to human factors engineers. So traditionally, human factors engineering has been largely funded by the Department of Defense, aerospace and aeronautics, aviation, and then maybe the nuclear power industry. Those have been the groups that have gone to academic organizations and said, look, we want you to do research on this. How do you make the system safer? How do you make it more reliable? And that has led to very robust systems It has led to improved ability to remove weak points in processes. It's led to communications improvements, things like heads-up displays in fighter pilots. I mean, think about that. This is about getting information to the person when they need it accurately, in a way that keeps them from, getting blown up in the sky. Well, I think we need that in intensive care units, emergency departments, NICUs, right? Operating theaters. We could use better information transfer. So where is it? Well, I don't think they've ever reached out to us. As I said earlier, when I first visited them, they were talking about nurses not being distracted. I think we can do better than that. There was a little bit of early work done back then on heuristics, which is failure modes. And most of the heuristics were about widgets. How do you make the glucometer easier to clean? That kind of thing. But I think that in terms of health systems, we probably need to be looking at how we work, right? How can you avoid miscommunication? How can you avoid missed opportunities for doing the right thing by improving the system of work? That relates to the built environment as well as widgets, right? We still work in a setting that was optimistically designed 200 years ago, right? These are buildings that look an awful lot like olden days hospitals with a lobby and hallways and a nursing station and rooms off the main hallway. I still walk into hospital rooms and I see bedside tables that look like a nightstand. And I get it. That's intuitively what goes next to a bed. But think about it. If there's a drawer and you open it, today you might find somebody's dentures. Yesterday you might well have found dirty underwear, right? And who cleans inside of that drawer? I can guarantee you that EBS is being yelled at to turn around the room because we've got 50 patients boarding in the emergency department. They're not cleaning the inside of drawers thoroughly on a routine basis, right? So why do we have a drawer there at all? It's a bad idea. I think that's just one of 100 different ways in which we can think about better ways to design a patient care area. Another one that I think is hopefully on its way out is the waiting room. Especially in outpatient settings. Do I really have to run the gauntlet of coughing, sniffly people in order to go give my insurance card to the intake person? We don't need to do that. Cheesecake Factory figured out 20 years ago that you can give people a beeper and let them wait outside. And so, I hope we're on the cusp of seeing improvements related to COVID experience and other things that are driving this. The use of telehealth has limitations, but it's been wonderful in a lot of ways, specifically with regard to not having to have people coughing in a waiting room. And so the list goes on and on. What is the best thing for wayfinding? Wayfinding is the science that tells you where you are and how to get to where you want to go. If you ever travel in large airports, do the test of wayfinding. When you step out of the airplane passageway into the airport proper, how long does it take before you're sure which direction to go? If it's a good wayfinding airport, you'll know almost immediately to go left or right, right? If it's not a good wayfinding airport, then you're going to stand there sort of rotating slowly, trying to figure out your bearings, or asking somebody for directions to baggage claim. Wayfinding is an interesting thing. What does it look like in a large American hospital? It's those 7 colors of tape on the floor that your 70-year-old lady is supposed to follow to get to the laboratory. It's not very sophisticated, and I think we can do better. Lastly, I mentioned things on walls. There's a field in human factors engineering called cognitive engineering. It's about how do you transfer information. It's the heads-up display stuff. The fact that we still see 4 pages front and back stapled in the corner and then taped to the back of a door as the latest information on COVID or anything else, that's crazy. We shouldn't have to do it that way. There have to be better ways. And so I'm looking at a lot of interesting opportunities to help people get the information they need, when they need it, how they need it, so that they can do what they need to do well. That is the cognitive engineering piece. I mentioned heuristics, cognitive engineering. The third one, just to be complete, is called macroergonomics. Macroergonomics is not in reference to a very large Aeron office chair like you might think. That's what I first thought. It's about how complex systems work within themselves. right? And so macroergonomics is about you bought the UV robot for room turnover, but no one ever thought about the fact that hospitals aren't built with robot garages, right? So the robot gets stored on the third floor in that one utility closet that has space. The challenge becomes if you're the EVS staff and you're turning over a room on the seventh floor, but you go down to the third floor, the robot's not there, where did it go? Right? There needs to be a system. I will also tell you that when our colleagues in industry first came to pitch the UV robots to CDC, this is over a decade ago, I can still remember them telling me how it's not going to take any more time than it already takes to clean a room. Because what happens is the human staff member wipes the room down, cleans it, and then the robot rolls in and zaps it. And while the zapping is happening, the human member goes to the next room and cleans it, and then the robot follows. And it was just this moment of realization, thinking that, oh my gosh, these people think that patients are discharged out of a hospital in a row, and they most certainly aren't. So it's that kind of macroergonomic thinking. How does the system actually work that we need to figure out? Because otherwise, every morning we've got 50 people boarding in the emergency department who've been admitted, but they don't have a bed. And I can tell you the hallway of an ED is not the place to be receiving care. Certainly from an infection control perspective. And if I were a patient, I wouldn't want that at all. So there's a lot to be done here, but also a tremendous amount of opportunity. Here are a few more things that I'll pop up very quickly. We are continuing to invest a great deal in that human factors world that is tying directly to some of the research that we're funding in training modalities. There's some early sort of prototype work with virtual reality. Currently, it uses helmets and goggles. That's not very practical for scalability, but we're thinking about how that then translates to something that is smartphone adapted. And then once we have smartphone adapted stuff, there's interesting science being looked at and funded to think about how do we gamify that? How do we make it fun to do? All of this driving towards growing that intuitive understanding of where's the risk? How do I keep from spreading it? How do I protect myself and my patient so that it isn't as mysterious? And when you look at a list of prescribed things during another Ebola outbreak, you're not going to be sitting there thinking, okay, this is a mysterious list that I must memorize, but instead you're able to look at it and say, okay, well, that's clearly because of this. Oh, and if I do it that way, that means I won't soil myself when I'm trying to take off the other thing. So got it, that makes sense. I'll do it that way. That's the goal. Granted, with millions and millions of healthcare personnel across the country, our task here is huge. But if we don't try, we'll never get there. So with that said, I want to say thank you very much for the opportunity to speak with you today. And thank you again to Drs. Manning and Marino for the opportunity. I'll stop talking and see if anybody has questions or comments.
And thank you, Dr. Bell, for a really fascinating look at this important work. I don't think any of us expected a Cheesecake Factory metaphor, but we certainly appreciated it. For our attendees, if you have any questions for Dr. Bell, please utilize the Q&A button. If you don't see it on your screen, try moving your mouse or tapping your screen if you're on a mobile device. Dr. Bell, we've received a few questions already, so we'll get started. And many of our attendees today are faculty members who are educating nurses of the future here at Jefferson. And one of those faculty members asks if, while acknowledging that it may be difficult to forecast, but what critical competencies or competency do you think will be most useful to practitioners in the future?
First, it's probably not just one. Nursing is one of those jobs where the suite of skills that you have to bring to bear to be great is enormous, right? It's interpersonal skills, it's self-management skills, systems management skills, it's negotiation skills, whether you're negotiating with a parent, a toddler, or the C-suite. All of those things combine to make you an effective clinical professional. And I'm not going to touch the clinical side of the house. You guys are professionals there. You know what you need to know. But it's the interface between what you know as a clinical professional and how you make it happen the way you know it needs to happen. So there's that knowing what you need to know, right? Or knowing what needs to happen based on what you know, sorry. And then there's that soft set of skills that makes you not just a technical expert, but an implementation expert. And I think that's one piece. The other one is related to that same skill set of soft skills, and it's about advocacy. It is related to advocating for what you know is the right thing to do and needs to happen. It's about advocating for staffing ratios. It's about advocating for all of the things that go into safe care that you see on the front lines. They might not be as visible to managerial staff, but the managerial staff is not always able to hear what we're saying. And so being able to deliver that information effectively, I think, is key. The other advocacy piece here, I love our patient advocates. They're treasured colleagues, but I also see that as an indictment to our medical system in the sense that I want to be the patient advocate. I want all of you to be the patient advocate. We shouldn't need extra people advocating for patients if we have the freedom to do our full jobs. And I see that as a symptom of the strain and fragility of our system right now, the fact that we have to have additional people advocating for patients when, golly, that should be thing number one under the label of nurse and doctor, right? And so I see those things as being important pieces that maybe people aren't talking about as much right now.
Thank you, Dr. Bell. We have a few questions, which I'll try to summarize, related to some of the partners that the CDC is working with on Project Frontline, or Firstline rather. now it's embedded, reminding me that my cat is due for an update. But could you speak to partners that the CDC is working with? Are you working with how are you working with maybe the American Nurses Association? Is there any involvement with the VA, Kaiser Permanente, and academic institutions like Jefferson, colleges of nursing around the country?
Yep. So let's see. Let's start with health systems. So obviously we don't maintain a separate relationship with every health system out there, but we do work very closely with the American Hospital Association and state hospital associations. They're a good way to get to health systems leadership that is different from frontline staff relationships. And that happens much more through professional societies and academic partnerships. The professional society partnership with ANA has been wonderful. The evolution of that relationship is something that we both wanted and are super excited about. The need here is not necessarily for ANA to do everything, but having ANA lend its voice and support to what we're doing was thing number one. And then also help us reach all of the subspecialty nursing organizations. We don't have the reach to speak to each and every nursing subspecialty organization, but ANA does. And by pulling them into the fold and understanding the needs of pediatrics nurses, people who specialize in infusion care, there's such a wide array of subspecialty nursing today. And it was important to us to be able to include all of those voices in the needs assessments that we do. It's also not a one and done. And so we look forward to ANA and other professional societies being part of the information source for what we need to do next. The first cut was more a reflection of the really obvious gaps that we see and have been dealing with for the past decade or two. But thereafter, we intend to do more. And a lot of that is going to be responsive to what the individuals in the fields tell us they need. And so that is something that we look to ANA to help us with. And then also to advocate for the voice of nursing. I think ANA has a really important role and opportunity here to make it clear that nursing is not a profession that can be commoditized. I hate to say it, but I think medical care in so many ways, whether you're a physician, a nurse, a PA, you name it, has become somewhat commoditized. And I think that's a slippery slope. I'm afraid we're halfway down it. And so clawing our way back up is going to take a lot of partnership and a lot of effort. And I think the voice of ANA is going to be leading that charge.
Thank you for that. Another question that we received relates to inclusion of elderly care and long-term care. So addressing and how the CDC is addressing sort of the care for frail elderly patients with multi-morbidity challenges to their immune system. Is that community and being addressed in some of your work?
Definitely. So first of all healthcare settings are included in what we do with Project Firstline. The elderly and the medically complex are not just one thing. They're not just nursing home residents. Some of them are at home, others are in group living facilities and so on. The long-term care picture is also not simple the way hospitals used to be simple. Just like we're dealing with ambulatory surgery and outpatient dialysis and so on, long-term care has expanded to become skilled nursing facilities, in addition to assisted living facilities, intermediate care facilities, behavioral health facilities, long-term acute care hospitals that are all ventilator patients. The waterfront there is tremendous. And we definitely engage actively with the professional societies that represent long-term care, as well as the health systems organizations that represent long-term care as well. The challenge there, as I said, is that moving overlap between medical care and residential care. Back in the day, all of the complex medical care happened in an ICU, and it was basic care that happened out on the wards. Now, a lot of complex care is happening on the wards, and basic medical care is happening in long-term care facilities. The number of nursing homes where people have urinary catheters, central vascular catheters, get complex wounds dressed, pressure ulcers and the like, I would say it's probably over half. And in that context, we can't treat them as just an apartment building, right? There needs to be a little more heft there. And the challenge that we have is, at the same time, this is someone's home, and we can't take home and make it feel like a hospital. So we are constantly sort of threading that needle, balancing those two ends of the spectrum. That actually is the genesis of enhanced barrier precautions. Many of you might be aware, for contact isolation in a nursing home, it's really untenable. You can't put a label on someone's bedroom door and say they're contaminated. That's cruel. Treating them with gowns and gloves for everything is similarly stigmatizing and not welcome. At the same time, you can't do nothing. And so enhanced barrier precautions pivots from addressing the individual to addressing the procedure, and saying anytime you're going to do a decubitus ulcer dressing change, you wear a gown and gloves, because it's likely to be contaminated, regardless of whether we know that that person has a resistant bacteria or not. And that way you're focusing on the procedure, not the person. And then we're actually working on, maybe to some extent, re-importing that back to acute care, because we also recognize that contact isolation is challenging. It's hard for nursing staff and others to maintain rigorously. We know what it's like when they actually do try to do it rigorously for something like Ebola, and it looks very different from what happens day in and day out under the signed contact precautions. There's a lot of cheating. And so if there's going to be cheating, what if we did enhanced barrier precautions for 70% of the contact isolation stuff, and then reserved contact precautions, real isolation, for the remaining 30% where we really mean it? There's that kind of conversation that's underway as a side benefit of the work that was done in long-term care.
And I know we're running close to the clock hour. If you just have a few moments, Dr. Bell, we have just a few more questions that maybe we can get to quickly. One relates to what role do you think the higher rate of travel nurses who may not be as aware of hospital policies, care implications over the past 2 years, may contribute to increased rates of infection? This is specific to urinary catheters and central lines, but in general, have you spent time looking at travel nurses and their impact?
Yeah, I think, it's a very important thing. I mean, I'm thankful that we have them. Like when you need nursing and you can get some, that's great. But there are two factors. One, they're new to the environment. And so they don't know where things are. They don't know how things work and they don't know all the people. And so they're getting their feet on the ground. And often by the time they do, they move on. And that means that whatever lessons were learned in that initial phase, we don't get to have the benefit of that learning. So there's sort of that dual frustration. I will share that that has led us to start a project of thinking about how we make all of the cues and signage related to infection prevention and patient safety the same across the country. Just like all stop signs are red octagons, no matter what county or city you're in, right, or what state you go to. If they all look different and you had to figure out every time you cross the state line, we'd probably have a lot more collisions. And so making something a little bit more homogeneous across health systems is possibly an opportunity to help a little bit in terms of alleviating the downside of that.
Thank you. Another question, you used the phrase intuition drives successful trade-offs. The question from one of our attendees is, while working with healthcare providers, what do you suggest is the best strategy to help them come along to develop this intuition?
Yeah, so I think this is where it gets both challenging but fun. So I have found, at least personally, that what's helpful in bringing people on board there is to have the thought exercise conversation, right? So you're in a situation, you're halfway through a dressing change of the decubitus, and you realize that the roommate just fell. What do you do, right? And what are the options? Okay, one, you could just go immediately pick up the roommate, but you've got schmutz on your hands. So the trade-off there is that the roommate gets picked up sooner, but they also get covered in schmutz. The other extreme is you stop what you're doing, you take your gloves off, you do hand hygiene, then you go, but then the person has to wait a minute longer. Is there a third avenue? Do you just yell for help? Do you use your elbow to bump the emergency call button? Right? There are all of these possible opportunities in that scenario, and each one has a thought exercise trade-off. The alarm button might be a good idea regardless, but it's still going to probably require a minute before the person receives help. There's the other piece of, was it I slipped and fell slowly, or I fell hard and hit my head, or I'm having chest pain and I slumped over, right? Those are all different things. And an opportunity to have that conversation helps the person, the learner, think through, oh gosh, so these are all the factors that I need to be thinking about. And then I make a decision, I always do, about which of those pathways to choose.
Thank you again, Dr. Bell. And it looks like we just have our last question here, which is asking if the collaborative learning model that you're using is based on the IHI collaborative structure, if you know or are familiar with that.
Well, so there are many models for this. There's the IHI, there's CUSP. This is less about the structure and more about the content. So you can actually take Project Firstline and plug it into collaborative learning models and use the stuff. And that's totally okay. It's not system specific. What sets apart Project Firstline is the focus on why, the focus on being able to understand what's behind the process so that you can not only remember it, but you can also defend it. I've met plenty of colleagues who ask for, can you put in writing that they have to do this, because they're not listening to me. And I think that there's opportunity here to grow that expert voice, if you will, because when you can tell people exactly why they need to do something and what the rationale is, you don't really need a document with a stamp on it that says, because it says so on this paper, right? That's far less compelling than a clear explanation of why this has to happen.
And thank you so much, Dr. Bell, and thank you for your time and your presentation. And thank you to everyone who has joined us this afternoon. We do encourage you to join us for some of our other upcoming events and lectures. You can visit jefferson.edu/alumni events to learn more about those. And if you're interested in learning more about some of the College of Nursing's newer programs and certificate programs, you can do so at jefferson.edu/nursing. Thank you all once again. Thank you, Dr. Bell. We wish you all a wonderful afternoon and a great weekend.
Thanks, everyone. Stay well.
Thanks. Bye.